Thank you so much, Peter, for the wonderful presentation. So I will introduce on behalf of me and my co-chair the next speaker, who is Associate Professor Iwona Szymusik. She is based in Hungary, and she's currently the Medical Director in Warsaw, in Poland, and she's the Medical Director at Gameta Warsaw Fertility Clinic. She has been working and did her fellowship in reproductive medicine, endocrinology, and fertility at Rush University Medical Center and Women's Health Consultant in Chicago. And she will talk us about endometrium. Is it something that we need to care about? Is it a challenge or not? Please, Iwona.
Good afternoon, everyone. I am really glad to be here, and I thank the organizers for inviting me to speak about thin endometrium. A challenge or not? I have no conflict of interest regarding this particular presentation. What I would like to talk to you about today is the problem of thin endometrium. Is it important? What is too thin? How often is it encountered? And what can we do to make it better? What are the strategies that are used or were used, and with what result? So is endometrium important? Yes, it is. It's on green light by ESHRE. We don't have many green lights there, so we might be happy that it's there. But what do we actually measure? We measure it somewhere around 1 centimeter from the fundus. We know that the thickness correlates directly with increasing estradiol. We know that it is related to receptivity and may be predictor of ART success. And we know that there are various controversies regarding the meaning of thin endometrium, many studies publishing different cutoff values. But we also have to know that there is an inter-observer variability of around 1 millimeter, and sometimes this 1 millimeter is something that we are fighting for to perform the transfer. And also there is an intra-observer variability of at least 0.6, 0.7 millimeters. So this is what we know. What is the cutoff value for thin endometrium? In the majority of studies, it's either below 8 or below 7, but let's not discuss the 7 and 8 range, because we all know that we will all go for the transfer to if the endometrium is 7.5. So let's discuss less than 7 then. We know that there are only case reports of patients that had endometrium less than 6 and conceived. Usually there are cases of of a patient having many transfers. What is the scale of the problem? We could say that when you go over the many studies, you can find around 2.5 cycles of IVF with endometrium of less than 7. How often do we encounter it in other studies? A study from 2018 from Germany, 1,400 cycles, only 0.5 women had endometrium of less than 7. And the authors said, oh, it's not relevant, so it can be ignored if it's measured at the transfer time. But they also wrote that only the extremes of endometrial thickness deserve further diagnostic workup, and this is what we are talking about today. When we look in the Canadian database from 2018, also the publication by Liu, to which I will be coming a lot today, Canadian database was big, 21,000 fresh transfers and almost 19,000 frozen embryo transfers, and they encountered the problem of thin endometrium of less than 7 millimeters in around 3 to 4% of cases. I was wondering where are all the patients in whom the transfer was cancelled, and it was not done because of the thin endometrium. They are not there, definitely, and they were not in the German study because the measurement was performed at the transfer day. What recommendations do we have? We don't like them because they write that it has negative impact and that we can offer cryopreservation. That's all. That's all we know. And in the end, a weak recommendation is that there is insufficient evidence that any specific protocol provides better pregnancy outcomes. So we cannot be happy with such recommendations, I guess. And in the same paper, there is a sentence that there is insufficient evidence to use any of the adjuvant to increase pregnancy or live birth rates in patients with thin endometrium. The add-ons were crashed yesterday, so I will continue, probably. Why do we have thin endometrium? We know all that from practice. Asherman syndrome, a rare case. We probably encounter many patients after DNCs, and we also encounter idiopathic thin endometrium, to which we have no idea because there is no history. Does thin endometrium have detrimental effect on ART success? Let's see. There are many studies, observational studies. They point to lower chances of clinical pregnancy rates and live birth rates in cases of thin endometrium, but they have different cutoff values. They have low quality evidence. Let's see, significantly less live birth rates below 7, less below 7, less below 8 and 7, so a mixture of everything, but many people point to the problem. Let's look at the Lu study that I came back again. She says, okay, clinical pregnancy rates below 7 and below 6 millimeters are definitely lower by around 40-something to 30-something%, so it seems important. There is an interesting study published in Fertility Sterility 2021, 96,000 autologous embryo transfers, and divided into age groups. This is an interesting observation. In each age group, it makes a difference, and if you drop below 7 millimeters, which is in the red circle, you can see how statistically it drops down, especially in the older women. So it's important when you look at the table here, below 6 millimeters, the clinical pregnancy rate, I think it was high because it's around 30%, but live birth rate is only 15, so they miscarry somewhere on the road. Of course, everything is meta-analyzed, so if we look at the meta-analysis, it's older because it's 2014. They say that the probability of clinical pregnancy is significantly lower for women with endometrial thickness of less than 7, but the result comes from retrospective studies, not from prospective studies, because up there you see the diamond crossing the line, so it's not statistically significant, but it's interesting. Let's go further. There is another one coming from 2022 from Liao. Few studies, almost all of them showing the difference, and again, it's detrimental if it's less than 7. Okay, does thin endometrium increase the risk of perinatal complications? Because we should look at that also, because we look at preeclampsia stuff with the frozen embryo transfer, but what about thin endometrium? Do we know anything? And the answer is unfortunately yes, because there are studies emerging saying that the risk of any placental complication is higher by 65%, that there is an increased risk of hypertensive disorders of pregnancy by 70%, 80%, and that there is also an increased risk of small for gestational age because they come together. So that's obvious. And this is the last publication that I found from 2024, the one in green. Thin endometrium before transfer in patients with less than 2 previous uterine surgeries gives you a risk of placenta creta spectrum, which we hate in obstetrics, and the risk is high because it's 5 times higher than in normal endometrium group. So we should pay attention, I believe. So what strategies do we have? 2016, we know the paper by Juan Garcia Velasco, the only green light that we had there is hysteroscopy. All the rest, unclear effect or no beneficial effect at all. So let's go for hysteroscopy. We do it. We know that uterine assessment may identify patients who may benefit from surgical management. It's still on green. It has always been on green. But we have no evidence regarding the relation between thin endometrium and, for example, chronic endometritis. So we did hysteroscopy, and it's okay. So what's next? Do you do natural cycle, HRT cycle for fat? Do you stimulate with gonadotropins? If you use HRT, what doses of estradiol, what route of administration, for how long? Do you know the answers to that? Do you do stuff like this? Do you use adjuvants like granulocyte colony stimulating factor, PRP, stem cells, growth hormone, whatever? Or maybe you just use simple vascular approach with aspirin, sildenafil, vitamin E, whatever there is. In Poland, people use also herbal medicine, but I have no knowledge on that, so I will skip. Okay, let's go over some of them. Juan Garcia Velasco put aspirin on yellow, but I believe that is no longer there because it doesn't work. There were no randomized studies. There was only one small one. It didn't show any effect, so I believe we cannot say it works at all. Estradiol lutulafase, it's on red. It's still on red, and it doesn't work. And there was also not many studies performing that, and adding 4 milligrams of estradiol at the time of trigger had no influence, neither on endometrial thickness nor on CPR, so let's skip that additional treatment also. Sildenafil citrate. I think everyone has tried. The idea was to improve the blood flow. There were many positive reports in the beginning, but then there was no improvement in pregnancy. In a poorly designed RCT, look at the RCT published in 2013. It's interesting because they showed that there was no improvement in clinical pregnancy rate when they compared 8 versus 10 millimeters. So how thin is that? And why was it even compared? Let's skip to something more sophisticated. Granulocyte colony stimulating factor. First reported by Gleicher in 2011. 4 women undergoing oocyte donation. Their endometrium changed from 6.5 to 7 to more than 7 after intrauterine administration of GCSF, and they conceived. So we tried to do that and repeat that, and other cohort studies showed that the increase in endometrium is around 1 millimeter, but there is no change in clinical pregnancy rate or live birth rate. And various studies published later in between 2013 and 15 showed conflicting results. So we cannot say that there is benefit. One RCT where GCSF was given to everyone. If we give something to everyone, it doesn't work. We know that. So how can we compare something like this? There is a funny study I found published not so long ago, 2 years ago. That's a meta-analysis, of course. 20 RCTs. According to the authors, GCSF increased clinical pregnancy rate by 80%. It increased endometrial thickness, but then after reading the abstract, I opened the paper and I found the IVF with thin endometrium. Sorry, this is a busy slide and has small numbers, but look at the diamond. It favors controls, so no GCSF. How come? How could this be published? They state in the results something completely opposite to what you see when you open the paper. So I really don't understand. I was confused, so I will not comment any further on this. I also found something interesting about growth hormone. There was an idea that the co-treatment with growth hormone could improve endometrial thickness and receptivity. By what possible mechanisms? By increasing endometrial blood perfusion, by increasing the expression of genes and proteins related to receptivity. The idea is very nice. It was also meta-analyzed, as always, showing the effect of growth hormone, of course, and the diamond is on the right side, and it works, but the subgroup analysis showed more obvious improvements in endometrial thickness at a dose of less than 5 units per day, only in long protocols, so it was all fresh transfers, not frozen. Okay, let's go to PRP. It was crushed yesterday. But do we use it this way also? Yes, we do. We know that there are a lot of growth factors and cytokines inside the PRP. We know that it might stimulate proliferation and regeneration. We know that angiogenesis is one of the key elements to help us grow the endometrium. So the hypothesis is that high concentrations of growth factors in PRP might improve endometrial thickness. First reports come from 2015 from Chang. Then few publications afterwards, they suggested higher implantation rate and clinical pregnancy rate after PRP administration. According to various protocols, PRP can be administered up to 48 hours prior to transfer. I wonder how it works when the endometrium is done growing. So I don't know. And again, the endometrial thickness may increase by 1.5 millimeter with an efficacy of 75%. So the increase in endometrial thickness is exactly like in GCSF group. Of course, it was meta-analyzed, so this is why I chose this. It favors PRP, not many studies. The whole group is only 311 patients, and 80% increase if you look at clinical pregnancy rates. Of course, if you look at the endometrial thickness, it's obvious that it grows. If it grows around 1 millimeter, then of course it will favor PRP. An interesting study published not with regard to IVF, but with regard to IUI in 2023 in AOG Global Reports. 120 women with EMT less than 7. They had at least, done at least in one stimulated IUI procedure, and they were divided into 2 groups. One received intrauterine PRP at trigger, and the other one received only estradiol. And the procedure was repeated through 3 cycles, or till they reached pregnancy. Endometrium was constantly growing throughout the first, second, and the third cycle, reaching 7.45 millimeters. But the positive pregnancy rate and clinical pregnancy rate after IUI was as high as 23%, comparing to 18 if you do nothing with thin endometrium. This sounds high, higher than I can do, basically. We have, of course, Cochrane. We are in Greece. This comes from Greece. 12 studies analyzed more than 1,000 women. They say that there might be an increase in clinical pregnancy rates with very low certainty evidence. The OR is 2.38, but the authors point out that they are unclear about the effect because only one of 12 included studies was judged at a low risk of bias. So it's not that great. This is something that was published more recently, the last one I found. It comes from Korea, so again, Asian papers, because Asian papers are leading in this matter. 91 women recruited throughout 5 years, so a long recruitment time. PRP was instilled up to 3 times from the 10 of the cycle every 3 days, up to endometrial thickness of 7, or up to endometrial thickness of 7, of course. They were all frozen embryo transfers, of course, done in HRT cycles, because otherwise you would have ovulation probably somewhere there. No other adjuvants were used, and they indeed showed that the live birth rate rose from 0 to 20%, and the endometrial thickness grew from 5 to 6.1, so around 1 millimeter that we know from previous studies, so it's constant. And there are some experiments on mesenchymal stem cells, usually performed in Asherman syndrome, which is a very rare case of ours. The Zhang and his group, they had 16 patients included in the study. They implanted a scaffold packed with MSCs into the uterus through the, let's say, on the Foley catheter. 3 months after the transplantation, the average endometrial thickness grew from 4 to 5.87. Some of those patients conceived, which is definitely a success. He also analyzed some other cases or cohort groups of patients with Asherman syndrome from 1 case report to 26 in a Yun Kao study. So it just might be a promising method for very rare and very difficult patients, but still experimental. So what I would like to conclude in the end is that the management of thin endometrium, although rare, remains a challenge for us. We still lack good evidence-based medicine to support any of the approaches I told you about. Some strategies, they might have some future ahead, but what is most important here for a take-home message is that we have to provide honest information to patients. We have to analyze published studies with caution because there are many things that are missing if you're reading just an abstract. So thank you very much for your attention.